is from the University of Arizona. She's going to talk to us about characteristics of disseminated coccidioidomycosis in pediatric patients.
Hi, good afternoon. My name is Sarah Zhang. I'm a third-year medical student at the University of Arizona College of Medicine, Phoenix. Thank you for having me here. Today, my presentation is on the characteristics of disseminated coccidioidomycosis in pediatric patients, continuing with our theme of pediatric population. So as you know, I'll briefly review the clinical manifestations of valley fever. In primary pulmonary infection, typical chest x-ray findings may include consolidations, nodules, interlobular septal thickening, lymphadenopathy, and pleural effusions. And rarely we may see a miliary pattern on imaging, especially in immunocompromised hosts. And when the infection disseminates to extrapulmonary systems, it can affect the central nervous system, causing meningitis, or the bones and joints causing osteomyelitis, or infections of the skin and soft tissue lesions. And typical laboratory findings of valley fever usually include a normal or slightly elevated leukocyte count. Also, we can see peripheral blood eosinophilia, which may be found in a quarter of the patients, and also elevated erythrocyte sedimentation rate, often 1 to 2 times above the upper limits of normal. In adults, the risk factors of severe disease typically include diabetes, older age greater than 65 years, cellular immunodeficiencies, including HIV infections with CD4 count of below 250, or conditions causing immunosuppression, including cancer, undergoing chemotherapy. And interestingly, that there's no evidence that malignancy itself, including hematological cancers, increases the risk of disseminated severe infections. These patients are at a higher risk infection only after starting chemotherapy. There's also evidence that those of African and Filipino ancestry are at much higher risk of disseminated disease. In the current literature right now, there's limited studies on that focuses primarily on the pediatric population, specifically to see if the same risk factors and clinical manifestations apply, which is what we aim to address in this study here. So our study was a retrospective cohort study that looking at pediatric patients who were diagnosed with disseminated cocci and evaluated at Phoenix Children's Complex Coccidioidomycosis Clinic from 2019 to 2022. So our study included 35 patients who were ages 0 to 17 with the median age of 13 years old. No mortalities were reported, and there was an even distribution by sex, 18 males and 17 females. Diagnosis of cocci was confirmed either through serology, culture, or histopathology. And we found that both the median absolute lymphocyte as well as the eosinophil counts was within normal limits. And we also saw that there was elevated ESR numbers, which corresponded what we had previously discussed in the previous slide. And this demonstrates how valley fever cannot be ruled out, even in a patient that we do not see overt laboratory values that show an infection. So out of 35 patients, 1 patient had a primary immunodeficiency, cytidine triphosphate synthetase 1 deficiency, and 9 patients, about a quarter of them, had secondary immunodeficiencies, which included short gut syndrome, autoimmune uveitis. Both of them were on disease-modifying therapy. Also, chronic venous sinus thrombosis, type 2 diabetes, acute lymphoblastic leukemia, and they were either on chemotherapy or post-chemotherapy, and as well as ulcerative colitis. And all of the patients in this cohort initially were treated with fluconazole, and 5 of them later had to switch to posaconazole, and 9 patients also received liposomal amphotericin B. So this figure here demonstrates the number of patients who are affected in each system with the highest number of patients with osteomyelitis and soft tissue lesion. We know that these two are often associated with one another, and followed by meningitis and pneumonia being more affected in these patients as well. And this shows that even patients who presents with extrapulmonary disease may not have a primary pulmonary infection or any pulmonary infection at all. And this figure here on the left shows the census data of Maricopa County in 2020 for those who were between the ages of 0 to 19. And figure 3 here shows the distribution of disseminated cocci in this study's cohort by race, with the highest prevalence in Caucasians at 37%, next African Americans at 34%, and Hispanics at 20%. So comparing these two pie charts, we can see that those of African heritage were disproportionately more impacted by disseminated disease. So in conclusion, this study contributes to the limited knowledge that we have about disseminated cocci in the pediatric population, and it helps us better characterize how disseminated cocci may present in this population. Also demonstrates that risk factors such as African heritage, also primary and secondary immunodeficiencies, which align with those that are seen in adults as well. So knowing about these risk factors, we can provide earlier diagnosis and appropriate treatments to better manage these patients effectively. Thank you for your time and questions.
Very nice talk. Thank you. Questions for her? Anybody?
Thank you.